and that is the interface lichenoid variants. Interface dermatitis we divided mainly histopathologically into two parts, but some of the people divide into three parts. Number one, it is the vacuolar variants, or this is also called degenerative variants. And the second is called lichenoid. Lichenoid being a pattern of band-like pattern present in the dermoepidermal junction. And third part of the histopathological variant of dermatitis, interface dermatitis, is perivascular and periadductal. Some people say periadductals, but mainly we divide into two parts. And another important point is that these all variants are sometimes overlap each other. You can see the same all features in lichenoid variants or LichenPL. So what is the important to think about the histopathologist? Today I will discuss step by step, and this is the presentation that we are going to start today. And as I told you that inshallah from the next year they are starting the FCPS in the dermatopathology. I hope this is the success of Dr. Zahid Irani and few other people who are working with the CPSB to start this specialty, and that will improve not only the knowledge but also the measures of the dermatology patients. So as I told you that what you think important in the interface dermatitis is number one, a presence of lymphocytes that may be band-like. When it is band-like, it is called lichenoid. Maybe sparse. When it is sparse, it is called vacuolar. One very, very important differentiation point. In the beginning, start at the end, I will ask, what is the exocytosis of lymphocyte? Write down on here. And what is the epidermotropism? These two different things, and especially dermatopathologists and histopathologists should distinguish that it is exocytosis of lymphocyte or this epidermotropism. Epidermotropism is always portary abscess and it is malignant, while exocytosis of the lymphocyte, usually we have discussed in many cases of spongiotic dermatitis and interface dermatitis. Second thing, that is the difference between spongiotic dermatitis and interface dermatitis is the damage of the basal cell. Damage of basal cells. Damage, what you mean by damage? It may be vacuolization. It may be metaplasia. Metaplasia of cuboidal cell to the squamous cells. This is very, very important thing. That is the differential point in the spongiotic dermatitis and the interface dermatitis. In some of the interface dermatitis, like LichenPL, it is very important that there is always basal damage and metaplasia of the basal cuboidal cell toward the squamous cell. 1 point. Second point is the interface alteration. Interface alteration, basal maybe liquefaction, maybe bulla formations, maybe degenerative pictures. And the third thing is when they separate dermoepidermal junctions interface, that keratinocytes are destroyed, and this destruction is called dyskeratosis. Usually you see in the basal layer, you can see these dyskeratotic cells can migrate toward the dermis, that is called colloid bodies or civet bodies. Today I will show you all these pictures. And then third, always you see the retirages in regular retirages in psoriasis, and by normal there are also some retirages. But in interface, there is a ragged or smuggy appearance of the interface. This smuggy ragged or smuggy appearance is the picture between the border between dermoepidermal junction becomes ragged, smudged, eosinophilic are the damage. And the third important thing, as I told you, when there is separation of dermoepidermal junction and there is change in the basal layer, the keratinocytes are destroyed due to necrotic process, these two apoptotic process, or due to some other pathological process, and they are called colloid bodies. Then they migrate, civet bodies, they migrate towards the dermis. This, and then as I told you, metaplasia of the basal cell is called schematization. This is maybe involve a basal layer, they can be extended to the stratum spinosum first layer. So these 3 to 4 important features are very important, and they differentiate spongiotic dermatitis from the interfacial. But presence of some other changes we divide into interfacial changes in the vacuolar, as we have discussed. And if some new people are sitting, we see our recording is available there. This is ये क्या है? What is this? As I pointing red, these are dyskeratotic cells, colloid bodies. These are dyskeratotic cells, colloid bodies. And in the dermoepidermal junction, there are infiltration of the lymphocytes. And the third important thing is that there is a small vacuolization and partition and separations, like something is, some eosinophilic material is present in the vacuole. This is the colloid bodies. So general concept of this one, as we have already discussed, usually histopathology, I concerned the Ackermann. And not only the Ackermann has also published the journals of the aware of the skin diseases. There is somebody. So I usually my lecture, most of the material is from the Ackermann. And the vacuolar, you see the dermoepidermis this is vacuoles. I'm showing them green lines, and this is, you can see dermoepidermal junction, a very small number of the lymphocyte, but lymphocytes are present. Some of the lymphocytes are present along the blood vessel. These are perivascular lymphocytes, and in the deeper part there may be periadynaxal and peri. So when such picture is present, we called it vacuolar pattern. And at the end, I will revise this picture again with different varieties of the vacuolar pattern of interface dermatitis. And the second picture, if you see, vacuolization is decreased, but there is a band of lymphocytes, a dermoepidermal junctions, and sometimes these lymphocytes looks reactive. Histopathology, new histopathologists confuse that either these are lymphoma, Pityriasis or something. No. But see, again, these lymphocytes are separately present. And among them, behind them, you can see some macrophages, some other pictures. While in malignant lymphocyte, there are only atypical cells. And one other important thing, right? All histopathologists, you can see some mitosis in dermoepidermal junction. What is the difference between malignant and the benign? Now, when there is a benign and in interface, you will always see a vacuole. This is called vacuolar mitosis, or in other words, it is called round body mitosis. While in malignant mitosis, there are hyperchromatic and variable picture and pattern and different trope-like different success. So this are the different, we will discuss one by one vacuolar variants, and we have already discussed, this is the lichenoid variants. Today we will discuss LichenPL and other things. This portion we will discuss today. Even syphilis, you always confuse. Very interesting case. One case came to me for the review, and the some of the person has given it the plasma cell tumor, but when I revise the slide, these plasma cells were benign, but there was other history that was the syphilis. So very important thing that you can devise if you have certain criteria in your mind. Okay, prominent band sometime in LichenPL, PPD, MF, and Hello, LK, and sometimes you see the vacuolar interfaces. They may be. Please please mute your mics. Okay, and sometime band-like and perivascular are in syphilis and so these are the picture when you sit alone, you revise, and if you get the time, 1 hour time, spend out these slides, get how much bands are present in which condition, when band and vacuoles are when mixed pictures. So it is different, very difficult to diagnostic approach, and as what is the density always say, what is the architecture of the infiltrate. Sometimes architectures will make you confused that it is superficial while the history is going further deeper, because certain interface when they are deeper, the diagnosis is changed, while if they are superficial like in lichenoid in discard, so they are a superficial, but when some other pictures when it is a deeper, then it is and what is the pattern of the alteration, either in the basal layer or in the deep layer, or there is vacuolization or there is band form. Sometimes you see the mucination. So mucin deposits. Sometimes you see the iron deposits. So you have to associated epidermal changes, infiltrate which type of eosinophils are present or not, because some of the interface dermatitis exclude when the eosinophils are present. Suppose if you are thinking some uh, EM and the eosinophils are present, then they are not EM. So this associated dermal changes and miscellaneous, but the clinical picture is very important. Again, some associated changes we can see atrophic versus hypertrophic, because atrophic sometimes you see in dermatomyositis, and while in hyperplastic you see in LichenPL. So retroregis blunting or sawtooth is very important. Blunting is seen one variant of lichenoid striatus, while sawtooth alteration you see LichenPL. So basket wavy appearance of stratum corneum versus hypo ortho or parakeratotics you sometimes see in different variants of LichenPL studable. Hypogranular, hypergranular spongiosis and basement membrane thickening is very important. Infiltrate, lymphocyte, or eosinophil. Sometimes you see the granuloma. Last slides, I will advise all the histopathologists that whenever you see some epithelioid cell, do not jump to the granuloma and take the history with this. These epithelioid cells are granuloma are due to tuberculosis or due to some other diseases that are present in this. So histopathologist is the key person to help other people, especially the clinicians. Sometimes neutrophil and atypical neutrophils. So these are different, we'll discuss diagnostic approach, the density, possible architecture of the superficial deep, as I have discussed pattern of this one. Sometime today we'll see also some, as I discussed, some mucins, some macrophages, some vasculitis, but do not confuse this vasculitis as the actual vasculitis. So clinical, it is very important. So we cannot make the final diagnosis, laboratory diagnosis, until unless with the incorporation of the clinical presentation. And at least you give 3 to 4 to 5 differential diagnosis when you send the histopathology prior to the biopsies. You also complete some immunostains, some other stains, some blood complete examination, some lymphocyte, because last time I shared a picture where all there was lymphocytosis. You have before this that was interface type of neutrophilic acute febrile dermatitis. So this is important for this one. Clinical plus histopathological, we can reach toward the lichenoid vacuolar interface dermatitis. So this is a beautiful picture. On this one, you can see we'll discuss in detail lichen planus and this different lichen and different other lichen keratosis. Sometimes see, sometime purpura can see. This is a picture of different lichen planus because.
Now, this is a really important part of the talk, the vacuolar and lichenoid types of interface dermatitis. Recognizing interface dermatitis is a crucial skill in derm path, and it's not that hard to do. What you're looking for, we call interface dermatitis because at the interface of the epidermis and dermis is where the inflammatory damage is happening. And what happens is lymphocytes come up here and they attack the basal keratinocytes for whatever reason. And in the process, some of the keratinocytes die, which gives you these little pink blobs of dead keratin. So people have called these lots of different names, but they're basically apoptotic, or some people say necrotic keratinocytes, but they're probably really apoptosis. Some people also call them cytoid bodies or SIVU bodies, depending on the clinical disease, or dyskeratotic keratinocytes. There's lots of different words. But the main point is pink blobs of dead keratinocyte along the basal layer. And white little bubbles or vacuoles. People call that vacuolar change or liquefactive degeneration. This is basically little vacuoles that are forming as the lymphocytes are damaging and destroying the basal keratinocytes. And a good kind of quick test for is there interface dermatitis or not, can you easily draw a line where the basal layer of the epidermis is, where the basal membrane is? Well, not really here, right? It's kind of blurry. See how it's blurred? It's not a clear-cut interface between the epidermis and dermis. Whenever I see that, that instantly makes me think, I bet there's interface dermatitis. Then I can go look for scattered lymphocytes, vacuoles, and dying keratinocytes. This is a very robust example here. Sometimes it's much more sparse and subtle, and you may only have some focal dying keratinocytes and little bubbles, but just keep that in mind, and you can go on higher power and look if you're thinking, oh, maybe there's interface change here. And finding this is really helpful because there are a list of diseases that tend to have interface and other diseases that really don't. So it really can help narrow down the differential diagnosis clinically. And here's some of the examples of diseases: erythema multiforme and the Stevens-Johnson toxic epidermal necrolysis spectrum, acute graft versus host disease, fixed drug eruption, lupus, and other connective tissue diseases like dermatomyositis, and on and on. There are others, but it's really helpful to find that because it can be very useful to the treating physician. So here's an example of lichenoid interface dermatitis. Now, I think of vacuolar and lichenoid as just two ends of the same spectrum. Both of them have vacuoles, lymphocytes at the basal layer, and dying keratinocytes. The difference is that vacuolar, like I just showed you, has relatively sparse lymphocytes, and lichenoid has like a bajillion lymphocytes forming a thick band right underneath the epidermis, okay? If you see a thick band of lymphocytes and you wonder, is this truly a lichenoid interface? Then go down closer and look for the dying keratinocytes. True lichenoid interface dermatitis should have dying keratinocytes at the basal layer somewhere, okay? So this is an example of lichen planus. Now, this is a...
So today, the first variant of the lichen planus, if ever you go to see some trees, some fungus-like picture on the stem, and this stem is destroying this fungus-like picture, this is a disease in the tree, but you can even see the linear picture of this. This is always associated with pruritus, as the clinicians usually they will, because last time some people request me that, sir, please always give some clinical hint before jumping toward the histopathology. So histopathologically is very important thing that epidermis is hyperkeratotic, the granular layer is prominent, and the hyperplastic epithelium forms irregular wedge shape or sawtooth. This sawtooth acanthosis is a characteristic feature in the lichen planus. Always right. This is one of the important differential diagnosis from other variant of lichen planus. And the wedge shape granulosus. Stratum granulosus becomes wedge shaped, while dermoepidermal junctions become packed is sawtooth or some jigsaw puzzle like pictures. Within the dermis, there is dense bands as we have seen in the picture. So before going toward detail, I will jump toward the histopathology. Again, I have showed lichenoid refers to the pattern of inflammation beneath the interclinical pruritus, and yeah, this is the carcocominal line. Clinically, where it is a present, very important, opposite towards the, and this clinically background stria is very important as, so different variants, variety, this is on, from starting from the flexor surface to scalp and to the armpit and the nails. Really, usually missed it that some people say that this is the fungus. Even the mucosa and spelling, this is a tongue, T-O-U-N-G, tongue. And then this is the skin again, and this is the purpura, and this also picture. So mucosa, teeth, and these are sometimes bushy, sometimes leafy, sometimes mixed. So most of the picture, this picture is flexor surface. This is usually comes to some, this type of comes to, this is called hyperplastic lichenoid plexus on this one. So I'm going towards the, so this is the picture. Sometime when you see whitish, reddish mucosa on this side, and you take the biopsy and you take the history, and when the histopathologist will see this one, it will see the hyperkeratosis. Keratin is the keratotic, then this is the granular layer, and then this is the dermoepidermal junction is effacement, and there is infiltration of this pictures. Arthokeratosis, sometimes basket variant. So usually when it is arthokeratosis, it is present in this one. You see granulosis. These are different picture. This is differential diagnosis that differentiate from the different variants. This variant is lichenoid keratosis in sun exposed area. I will discuss in further in smaller. Showing here the granulosis, showing here some effacement of the dermoepidermal junctions. This is hypervariant of the, this is the differential diagnosis in histopathology that people will say, no, this is squamous cell carcinoma. So it is not squamous cell carcinoma. It is not follicular variant squamous cell carcinoma. No doubt the rete regions are extended, but see other pictures, dermoepidermal junctions, and the sawtooth appearance of this one. And the granular layer becomes wedge shape. I will show if you go on the higher picture, hypertrophic lichenoides is just like it makes picture this one. Showing this one, civet party that is present in the dermoepidermal junction as we discussed earlier. What is this? This is the basement metaplasia. Usually on this side, you will see the cuboidal cells, while these cells, they are going toward the basements are becoming squamous. The squamatization of this one is a very important feature of the lichen planus. So again, I am trying to show this civet bodies and wedge-shaped hypergranulosis and arthokeratosis and sawtooth appearance are jigsaw puzzle-like dermoepidermal junction. I will highlight another slide. Where beautiful dermoepidermal junction is sawtooth-like, and if you see the granular area hypergranulosis, but wedge-shaped granulosis. This is the another characteristic feature of this. If you see here on the vessels on the adnexa, you see same changes at the dermoepidermal junctions. And this is some melanocytes. You can see there is a civet bodies, and they are so again, this is wedge shape hypergranulosis. Wedge shape hypergranulosis. While dermoepidermal junction become sort of appearance. Again, I am trying to show this one. The regression, sometimes you can be confused with this one. This was legend planus planopilaris, some variants only, other areas are normal, but this legend planus involving this is subtype of the variants on the perifundicular area. May have area of the dense lymphocytes around the follicles as one. Lichen planus pigmentosus. This is also a variant of dermoepidermal junctions pigmentation. This is called I highlighted this one. This is wedge shape hypergranulosis. Basal layer disturbed. I show another picture of this one. This is wedge shape hypergranulosis. Wedge shape hypergranulosis. This is called sort of jigsaw puzzle-like appearance. So microscopically, we parakeratosis. This is epidermal thickening. As if you see in the dermoepidermal junction, this is schematization, and then there is lymphocyte infiltrate, then epidermal damage, then eosinophils are not important, but sometimes present in this one. And lichenoid tissue reaction sometimes see. Fixed drug reaction you can see, but the history is very important. When you diagnose the fixed drug reaction, keratinocyte ballooning and individual necrotic keratinocytes are present. Classical interface may or may not be present, but in this case, dermoepidermal eosinophils are present, while the orthokeratotic stratum basalis stratum cornea becomes basket wavy, and there are the neutrophils. These are some additional findings of histopathology which not usually seen in the lichen planus. This is the picture of this one, ABCD. The same fixed drug reactions, a basket like that was orthokeratin. This is the basket wavy stratum corneum. These are keratinocytes ballooning. When it is ballooning, and these are eosinophils pigments. Incontinence, these are eosinophils. Sometimes these eosinophils confuse with the plasma cell, and sometimes they confuse with the RBC. So it is the histopathologist to differentiate among plasma cell, a single nucleus, rounded nucleus, eccentric nucleus, while eosinophils are multinucleus, more pink, and even sometimes mast cell can confuse. And while the in RBC, they are present, they are nucleolus, no nuclei are present. Again, sometimes this drug reaction, sometimes Q neutrophil, and this is the RBC. This is RBC, eosinophilic material, vacuolar. So sometimes lichen planus in purpura, you can see some other picture that is called the iron stains. These are iron stains. You can stain with these are the iron pigments and can be stained with the pearl reactions. These are seen in purpura. So what is this? If you go on again, this is the picture of this one vacuolar variant. Oh, beautiful picture. What is this? Clinicians can help me. Spot diagnosis of this one. Tested acute. This is another variant of this one. This is another picture. That is the Pityriasis lichenoides. Pityriasis lichenoides occur in two clinical forms. What is the acute It is called pleva. And some other clinician name and other things. And it's very rarely you can, a patient comes to you in the clinic. That is called Pityriasis lichenoid chronica. In acute form, it is very difficult to differentiate, but certain histological point hint I will give to you. One is the rule out the history. Second is timings of the taking of the biopsy. And the third other investigations, histology, chemical investigation and the blood hematological investigation. Timing of the biopsy is very important for pityriasis lichenides. Then because these overlap with the lichenoid interface dermatitis and vacuolar dermatitis. In acute form, usually you will see the spongiosis. While all the picture will you see this, it has confluent bound parakeratotic containing lymphocyte and neutrophil. Epidermal necrosis can range from single disc keratosis to full keratosis, जिसको हमने colloid body कहा था, but they can be in collection. Intravascular fibrins deposits sometimes confuse that either this is the mucin or not. And wedge shape or broad layer lymphocyte infiltrate or lymphocyte exocytosis. Another important thing at the end, I will show you the picture. What is the exocytosis and the epidermotropism? Pleva characteristics. Number one, neutrophilic parakeratotic crust. This can be confused. The lymphocyte exocytosis is hardly seen. Exocytosis is when the single cell present in the lacunae is called exocytosis. When many cells without lacunae are going toward the epidermis, they are called epidermotropism. Very, very. Doctor, at the end, will note the question, and at the end, inshallah, I will ask you a question. Once again, exocytosis you can see in different inflammatory diseases mean a single cell, single lymphocyte going present in the epidermis but present in the vacuoles. In lacunae, एक लेकुनी होती है जिसके अंदर लिम्फोसाइट पड़ा होता है, वेरी पिक्नोटिक टाइप होता है. While when the groups of cells, lymphocytes, atypic cell are moving towards the epidermis without damaging dermoepidermal junction, very important, without damaging dermoepidermal junction, this is called, usually called, but then later on you can see the effacement of the reticulus, but in the beginning there is no effacement of the reticulus in the epidermotropism. And the second important thing is that the extravasation of erythrocytes. I told you RBC, how you can differentiate RBC, you can differentiate in mast cell, you can differentiate plasma cell, you can differentiate eosinophil from the erythrocytes, because these all things are very important for the beginners. And characteristic features are superficial and deep perivascular. Well, mostly in the lichen planus, we see the superficial. Hardly the lichen planus involve the deep pictures. When it is deeper, when all these pictures are present, so, and periadenoxal is very important picture, especially no eosinophils. This is the same picture. Once again, I am trying to show you. Parakeratosis. So this is the deeper picture. This was pityriasis lichenoides. While some MCQ questions can show superficial and deep perivascular infiltrate present in acute form of pityriasis, while only superficial in the chronic phase. Lymphocyte can have atypical morphology, as I told you, sometime but see other lymphocytes, either they are present in a single form in a lacunae, or they are in a group of cells. Another note, the mitosis, if the mitosis is abundant, then their lymphocytes are malignant. If there is spores or 1 or 2 mitosis, then they are exocytosis of the lymphocytes. Usually these are T lymphocytes, and atypical CD3 can be reactive. These are not actually atypical, but these are atypical. So this is another picture, parakeratosis, spongiosis, please, that we have already discussed in detail. And starting from stratum corneum, come down. This is these are the RBCs present. These are RBCs present, access to RBCs, and these are the lymphocytes. And you note these lymphocytes are present in around the halo. There is halo around them. So this is the picture of this exocytosis. So Pityriasis, lichenoid, veriform acuta, and in the chronic form, this is the chronic form, you see there is less vacuolization, there's less spongiosis, there is a less band-like pictures, but there is present in the superficial, while there's no deep picture, though need involved on the lymphocytes. This is a classical picture you are looking here. The tree, the shrub-like picture, this is called a wedge-like picture. If you draw a line, it becomes a wedge-like picture of this one. Neutrophil, these are the classical variant of, as I told you, I will show you the exocytosis, differentiation of the epidermal tropism. When you look like this lymphocyte, either it's looking you reactive, looking you pycnotic, looking you destroying, it is benign. And when such vacuoles are not seen around, this is a very important thing to understand the histopathologist. Okay, either it is a lymphoma, or it is pityriasis, or it is in the lichen planus, and also combine other features which are not seen in don't confuse yourself with the pityriasis or something else. Extravasation of the R, I have tried my best to differentiate these, and beautiful picture of this shrub-like pictures, always some pictures. These are lichenoid superficial wedge-like picture, lichenoid pityriasis. And difference between lichenoid pityriasis and lichen planus retiratus. In the lichen planus, they were juxtaposed. They were not round. They were not finger-like. They were not thumb-like. While in pityriasis, pityriasis, they are rounded. And you see some, depending upon the stage of this superficial and other thing. So eosinophils are not important sometimes. Okay, another variant, that is the smaller variant, that is called lichen planus, lichen striatus. When the lymphocytes are present, the eccrine glands deeper, and while this is a localized collection, it is of lymphocyte, it is called lichen striatus. Perivascular lymphocyte are sometimes confused. So one other people, when the lymphocytes are seen around, and the clinician gave the history that there is a linear atypical plaques on the armpit or on the external surface of arm, then on the histopathology you see a localized dermoepidermal effacement by lymphocytes, and the lymphocytes are involving the eccrine glands. You see some other cells, not only the lymphocyte, but some other cells. What are other cells? They can be epithelioid cell, they can be histiocyte, they can be macrophages. So these 3-4 points can differentiate granuloma and lichen striatus And this is the linear picture present. There's a classical, clinician will tell you that this is the hallmark of lichen striatus and distinct linear band-like picture, this one. So on histopathology in the Ackerman, you will see the focal, localized, not all the area are involved, mild acanthosis, mild maculization, but lichen striatus. Important thing, variable lichenoid pattern, can be near granuloma, periadinaxal, especially acrine glands. I have tried my best to show the deeper it. This is the acrine glands. These are involving, but this is patchy. This not homogeneous. It is a patchy, almost dermoepidermal junction. You can see there is less vacuolization of this one. So this is again a confusing picture between statins, lichenoid striatus and ititis. When the very important, this is retirage, one retirages, this is the second retirages. When between the cell, they are not making a ball or they are not making a sitting chair, then it is, and involving the deeper picture, then they are as lichen striatus. So sometime I have made round, this is not a ball, that when it is a ball is fixed in the jaw. So these retirages are rounded while lymphocytes are present among them. While in other areas this is almost normal. So this is the lichen striatus. Here you see one or two, this is histiocyte. These are epithelioid cells. These are some other cells. So this can confuse histopathologists. This is a granuloma. Because histopathologists भी अपनी जान छुड़ाता है यार, जान छोड़ो यार, इसको granuloma करके जान छोड़ो. So do not go like this. Take another history when you see the granuloma. We will have a one lecture, inshallah. Professor Ghulam Rasool Qureshi, my teacher of the teachers, who gave me a very beautiful presentation of the granuloma of different diseases. Inshallah, we discuss. Another picture that is called Lichenoides. Described focus say similar picture as I have discussed, but in this picture you cannot see the joint cells, but in this picture you will see giant cells, multinucleated giant cell. In lichen striatus you cannot see some in ititis, it not involve the deeper picture of the acrine glands. While very important feature that lymphocytes are captured in a ball-like pictures. This is a picture, this one. This is ball-like. That two retirages are catching like a ball in your hands. You are catching a ball in your hands. If you put a ball here in two retirages, it is a ball, then it is a lichenoides. And if they are not involving, so this is a ball-like picture. This is not seen in striatus, but almost other features and all same this one. Or sometimes it is a chair-like pictures. 18th century, this type of the chair was designed for usually for higher class, but still in Lahore you can see such type. So you see here, it is like a chair-like picture, sitting chair of this one, all ball-like pictures. What is this? This is a ball. This is not striatus. This is a ball. So this is a granuloma. You see some joint cell, multinucleated giant cell. This one. Sometime in porokeratosis you can see it, but take the history of this one. Syphilis. Early in the morning I told you, starting this one, always differentiate plasma cells. At the end, this is the summary of this one. What are the vacuolars? We started our lecture from this picture and we are ending our lecture at this picture. What are different variants of vacuolar pattern and what are different of lichenoid pattern? I am going to solve the problem of all histopathologists to giving one table, print that table whenever you sit on the microscope, you open this table and compare the history and see the table and then see the microscope. It will help you in the diagnosing the interface dermatitis. So this is the table. I will separately send this table to you all pictures that different stratum interface dermatitis. What will you see in the stratum corneum? What will you see in the stratum spinosum? What changes you can see in different diseases? On this blue picture, you are looking the different diseases. On the vertical pictures, you are looking different. What will you see the, especially always consider. So this was all about today, and thank you very much for your concentration. मैं एक सादा सा हिस्टोपैथोलॉजिस्ट मैं एक बहुत ही सादा सा हिस्टोपैथोलॉजिस्ट हूँ. That the knowledge all to me, जो कुछ भी मुझे पढ़ाया, that was due to my teacher, Professor Ghulam Rasool Qureshi. And whenever you go to home, please recite Fatiha. कल को हमने भी नहीं होना. To the Professor Ghulam Rasool Qureshi. Thank you so much. Now, Dr. Zahra Batul, you have raised the question. A hand, please ask the question.
Sir, I just wanted to ask that when you are taking an exam, if you see an interface dermatitis and you give all the points for it, like there is basal vacuolization, there is dyskeratosis, there is exostosis, there's dermoepidermal display of lymphocytes, there is squamization of the layer, the basal layer. Is it enough that you don't categorize it into the other categories?
Very good question. I have reached your question. Yes, if the dermatologist has not given the differential diagnosis and sent to you the tissue for histopathology, you can give the report like this. But if the clinician has given you the detailed history of the patients and have given the 4 or 5 differential diagnoses, and you tried 1 or 2, then it is very important for you that at the end I has given you the 1 or 2 points for each differential diagnosis. And you can even don't hesitate to consult your slide with your juniors. Don't hesitate to consult your slide to the seniors. I think when their dermatologists request you to reach the actual diagnosis, then it is very important for you to spend 1 or 2 days on it, on the slide, and try to reach the final diagnosis.
Thank you, sir. Thank you so much.
Especially for you people, histopathologists, in the last picture, and that always differentiate with the benign pictures first, and then after that, then go towards the infectious diseases, and then go towards the any malignant diseases. So this is the dilemma in histopathology, that we jump out towards the granuloma, we jump out toward the some lymphomas, and Dr. Isaac knows that whenever we put the slide in our histopathology group, surgical group, usually the diagnosis is malignant. So that is okay. Any other question?
Thank you, sir. Thank you so much.
Thank you, sir. Thank you, sir. Thank you, sir.
Any D. Dr. Zunaira?